Good morning. We'll give folks a couple more minutes to jump on. Good morning again. Welcome those who just got on. We're giving folks another minute to join.
Good morning, Kathy. Morning, everyone.
Good morning again. Giving folks about 30 more seconds to join, and then we'll start with introductions. Welcome, folks. I think most of you know me, but for those who don't, my name is Kathy Kilrain Del Rio. I use she, her pronouns. I'm the Advocacy and Programs Director at Maine Equal Justice and the chair of the MAC. And I missed you all last month. Thank you, Mallory, for filling in. We're going to start off with our normal introductions. And my apologies, I have this like annotated version of the list that I seem to have moved out of the folder where it should be. So I'm like going by the list that's online, but I don't think it's completely up to date. So if I mix up anything.
I found that out last month.
But so I apologize in advance because there's going to be a few mistakes, but we'll get everyone introduced. And I will figure out what I did with my document I usually use before next month. So again, names, pronouns, and what brings you here today, your organization or affiliation. And starting with Piper Stiles. Catherine Brandt. Ian Yaffe.
Hey, Kathy.
Hi, do you want to introduce yourself for folks?
Sorry, I missed that part because I didn't hear anybody else. Ian
That's okay.
Yaffe, I'm the director of the Office for Family Independence here at DHHS. I use he and him pronouns.
Thank you. Jamie Cottonwar. Mallory Shaughnessy.
Hi, Mallory Shaughnessy, Executive Director at the Alliance for Addiction and Mental Health Services and Vice Chair of the MAC, Chair of the Provider Subcommittee. If anybody's interested in joining those meetings, please do let me know.
Kathy Dion.
Hi, Kathy Dion. I'm the Executive Director for the Autism Society of Maine. I have an adult son who is a MaineCare member, and I use she, her, hers.
Becca Matasovich. Or Kaylee Hess. Vicki McCarty. Rachel Collmore. Or Helen Roy. Sarah Squire.
Good morning, Sarah Squires, she, her pronoun. I'm Public Policy Director at Disability Rights Maine.
Gia Drew. Lisa Weaver, there's someone on their phone that's not muted. Would you be able to help with muting them? Susan White or Lori Belden? Catherine Hamilton? Leo Delicata?
Good morning. I'm Leo Delicata, he, him pronouns, and I work for an organization that has changed its name. It was the Legal Services for the Elderly, but as of yesterday, we are now Legal Services for Maine's Elders.
Oh,
Thanks.
thank you for letting us know that, Leo. Sarah Lewis?
Sarah Lewis, she, her pronouns, and I'm with Maine Access Immigrant Network.
Laura Cordes?
Hi, good morning. Laura Cordes, she, her, hers. I'm the executive director with the Maine Association for Community Service Providers, MAXPE.
Rachel Dyer? Or Nancy Cronin? David Winslow?
Good morning, David Winslow with the Maine Hospital Association.
Dan Morin? Oh, I'm sorry, not Dan. Is there anyone here from Maine Medical Association?
They haven't gotten back to us yet, Kathy, with
Oh,
who they'll appoint.
thanks, Kayla. Bobby Martin?
Hi, Bobby Martin, he, him, Director of Community Health Innovation for the Maine Primary Care Association.
Candy Henderly?
Good morning, Candy Henderly. I'm the Director of Health for the Penobscot Nation. She, her, hers.
Teresa Cochran? Or Kristen Goddard? I saw Becca Matasovich join. Becca?
Morning, Becca Matasovich, Children's Oral Health Network of Maine.
Is there anyone else who's a MAC member or alternate who joined and we missed you?
Morning, Kathy Marquez, he, him, alternate to Laura Cordes at MAXPE, Executive Director of Woodford's Family Services. Good morning.
Morning. Okay, let's pass it over then to Maine Care Services. And Kayla, I see you first, so I'm going to pass it to you.
Thanks, Kathy. Hi, everyone. My name is Kayla Sargent, she, her pronouns. I'm the Director of Strategic Planning and Communications with the Office of Maine Care. And I am going to pass it over to Sarah Fisher.
Good morning, everyone. I'm Sarah Fisher, she, her pronouns. I'm the CHIP Outreach Coordinator for the Office of Maine Care Services. Let's see, Lisa.
I think Lisa may be having some technical issues. So I'll go next. Hi, everyone. Kristen Merrill, State Plan Policy Development Manager for the Office of Maine Care Services, currently acting Policy Director, she, her pronouns, and I will pass it over to Sana.
Hi, everyone. Sana Osman, Members Engagement Manager at the Office of Maine Care Services. And what do I see? Amanda.
Good morning, Amanda Lee, Rate Setting Coordinator, the department, and I use she, her pronouns. Sorry, my mouse isn't working. I'm trying to scroll through here.
I think that you're last, Mandy. It looks like Molly introduced herself in the chat.
Okay, thank you.
And just going back again one more time, if there's any MAC members or alternates that we missed. Are there Oh, go ahead.
I'm Mariam Bashir. I use she, her pronouns, and I'm a student of public health over at the University of Southern Maine.
Thank you. Welcome. And are there any guests? You can either introduce yourself by coming off mute, or you can put it in the chat.
Hi, good morning. My name is Jessica
Go ahead,
Drenning.
Jess. I was gonna
Sorry.
introduce you, so go ahead.
Yeah, my name is Jessica Drenning. I am the new Senior Main Care Program Manager with the Office for Family Independence. I assumed Leah Studholm's previous position, and this is my first time attending a MEC meeting, so thank you.
Welcome. Anyone else? Oops. Okay, so then let's go ahead and jump into our agenda. We're gonna switch the first two agenda items because Michelle Probert is running a little late. Hopefully that's okay, OFI. So we're gonna do the agenda item around unwinding and how things are going and updates from the last meeting. And Ian, is that you or is it Jessica?
Yeah, I can take that.
Okay.
Great. So good morning. Thanks everybody for joining. We have lots of updates to share about unwinding since the last MAC meeting, and I'm happy to go sort of as in-depth to them as you would like. We also are going to have a dedicated stakeholder meeting about unwinding next week on February 13th. I think at 3:30. I'll put the Zoom registration link in the chat if anybody wants to join, but I'll sort of cover the highlights here, and then we're going to have a special briefing about that next week for anybody who would like to learn more. And so I think there's three big picture things that I wanted to cover. And let me put let me put this link in the chat. So we have an update from a couple weeks ago. Michelle and Hillary from Cover Me and myself briefed the legislature's Health and Human Services Committee about unwinding. So this blog post has a summary of some of the updates that we had last month, as well as a link to those slides. We are now over 50% through the unwinding period, and so through that process, over 200,000 Maine Care members have successfully renewed or retained coverage, including 30% of them who were renewed automatically without completing a renewal form through the passive or ex parte renewal process. You had some questions about timelines here for the pending folks, and we have some updates on that. And so as we are still building our capacity to do the passive renewal process at the individual level instead of the household level, we expect that to be implemented in July for renewals that will be due in August. And so for all of the current members who are pending, they'll be scheduled for renewal determinations between August, September, and October of this year. So that's sort of the new end date for unwinding. Originally, we were anticipating that would be done in May, and now that will be October 2024 is sort of when we will have everybody either have their renewal rescheduled due to the passive ex parte process, or at that point you'll have members who were renewed successfully during the original unwinding timeline, and then they'll be coming up for their for another regular renewal during the same time period. So that's, and I can share my screen briefly here just to show the timeline, if that's helpful to have a visual. zoom in a little bit, but it's not gonna, hold on 1 second. I think that's about as best as I can do without just constantly playing with it. But so this is what our timeline for unwinding looks like now. We received approval at the very end of December for this, and we're able to construct this plan. But again, the significant update since the MAC meeting last month was that the new anticipated end date for renewal determinations is October 2024. So I will stop. I'll leave this up maybe for a moment if anybody has any questions about timeline, because I know that was a question that folks had last month.
I'm not seeing any questions.
Okay.
Oh, I'm sorry. I do have a question. I was having
Oh.
trouble getting things. So Ian, thank you for that update. I joined late, so forgive me if you said this, but there's about 50,000 or close to some 40 to 50,000 people who didn't renew. So will they lose their main care if they don't take action? Are you saying in October?
It depends on the specific person. Basically, so in the current, and I'll pull up the current data here. So this is our renewals dashboard that I think we've talked about a little bit before. And these data are actually, this just got updated at the end of last week. So these are the numbers through January. But as you are describing, Kathy, there's this population of people that their renewal hasn't been completed yet. Often, I think some of those are current renewals that we just haven't finished processing, but the majority are people who are in a pending status because they didn't respond, and they're still open until we can complete that ex parte process at the individual level per the CMS compliance requirements that were shared in August. And so that's the population that will be rescheduled for renewal once we have the technology in place to do so. And they will be rescheduled sometime between August and October. And so at that point, once we get to the end of October, some people's renewals will be due in August, and they'll have to complete the process by August. Other people will be scheduled for September and October. And so depending on what month their renewal is scheduled for, they'll need to complete the renewal process in order to retain coverage. We hope that the passive renewal rates will increase once we do this at the individual level. But certainly that's the time period that I think most folks here will be concerned about, is people who never responded to the first renewal request, or more than the first renewal request, but the first one during unwinding. And now we'll get a second renewal request. It'll be in the same blue envelope. All the messaging is still the same, but this is the time where if they don't respond after that renewal, that's when coverage can be closed for procedural reasons, where currently we're not closing coverage because somebody fails to respond.
And so if someone's up for renewal this month and they don't respond, they'll continue to go into that bucket, so to speak, like until August, or so that bucket we'll see that bucket continue to grow.
Exactly. Yeah, that bucket will continue to grow each month until May. That's the last month of our current scheduled renewals. And then those folks that are still pending for unwinding at the end of May will be rescheduled once we can do that in July. And so those renewals will be due in August, September, and October. And we can have a better update, I think, closer to the summer on exactly how that, I'm sure there's a question of like, how is that population going to be scheduled, and who's going to fall in what month. We can work on an update on what the methodology is for that. But I think the big answer is still sometime between August and October everybody will have to complete their renewals. And again, hopefully a lot of people will complete that through the passive process and will have their coverage extended.
Thanks so much.
Great, thanks.
Bobby?
Thanks, Ian. That's really helpful information. Do you have a demographic picture profile of that 50,000 group?
We are building that and hope to include some information about that at next week's meeting. We're still crunching those numbers to see sort of who is either sort of overrepresented in the pending population, or for the folks that have been closed now for failure to verify, which is a very small number of people. We're also looking at those, but I think by next week we should have some more information to share about that. That we'll get to you, and then we can do the same deeper dive on that with this group in March, if you'd like.
That'd be great. Thank you.
I don't see any other questions. And did you have other updates you wanted to share?
I know one of the standing agenda items is like, what can MAC members do to help? I'd say, nothing has substantively changed in that advice. We're still doing all the things that we can to maximize coverage, and appreciate the partnership with folks here. I think we'll have some updates as we get closer to the summer on if there's, what that additional campaign might look like for the August through October time period. But I think at the current time period, there's nothing that has changed about what folks can do to help. And we, still encourage people to submit their renewals, and respond and get coverage extended if, when they get that letter and still expecting it. So thank you for all the work that folks here have been doing with communities to keep them informed of the process, in addition to the work that we're doing through on our end to let them know what's going on.
Thank you. Any?
Kathy. Yeah. Sarah Lewis. Hi, Ian. Someone just asked, and I'm on the phone because I can't see who asked, but I appreciate the question of a demographic breakdown of who we've got left, because I feel like if we've got folks who do not read English or do not speak English, I wonder if there's an appropriate targeted, focused way to reach out to them with already contracted organizations. For instance, I'll throw Maine Access Immigrant Network out there. We would be more than happy to work with the state, on this unwinding work if there's focused outreach, where meaning we're focusing our outreach to our client population, but there's just so much you can say something in a campaign. I wonder if there's actually a need for picking up the phone and calling over WhatsApp, for instance, or, there's patient confidentiality, so I don't know how that would work, but I just wonder if that's something that some of the contracted ECBOs could help with, because they know it's a small population and everyone knows everyone. And we, would probably be able to help. We might be able to leverage that kind of outreach to a level that's beyond just a poster.
Yeah, that sounds good. Thanks, Sarah. I think we should certainly by this meeting next month be able to share some of that initial information. I don't think there's, so far in the preliminary review, I haven't seen anything super surprising. So I think that conversation will be well placed. And we can also share some of our feedback in the legislative briefing. We described some of the, just what's the current sort of call posture at OFI and all the different texts and email notices that we're sending. So I think this will be a good conversation about if there are some focused groups that you have suggestions about. And we can share with some of our experience about, the success of, what our success rate has been calling people and things like that. But thank you for bringing that up.
Any other questions or ideas?
And maybe
Anything
just to reiterate, everything is the same until the summer. So I think that's the other thing to remember is while our timeline is extending, that extension, the reason for that extension is this technology change that won't occur until July. And so nothing right now is changing about unwinding in terms of messaging and communications. It's all, what is our communication like once we get through the full scheduled 12-month renewals in May?
Thank you. Anything else you'd like to share? Okay. Kayla, I'm looking at you because I don't think I see Michelle yet. Should we move to your update next?
Yeah, I think we could do my update and then we could move into the provider updates. I'll pass it over to Bill for the technical update on enrollment. And then we can have Michelle once she joins. All right, great. So I wanted to share an update. We held our provider enrollment presentation session last month on January 17th. We opened up that session. The first half, MaineCare and Gainwell presented on the provider enrollment process. And then the second half, we opened up the floor for providers to submit questions or to come off mute and ask questions. We had a lot of success in terms of the volume of engagement. We were very pleased with that. We had 381 people attend, both online and in person. And we addressed 8 questions from providers verbally during the presentation and received 167 questions and suggestions via the Q&A box. We're in the process right now of reviewing and responding to all of those questions. We're working on consolidating and theming them so that the end result is a useful list that's easy to navigate for providers. Right now, we have the presentation slides posted on our webpage, and I'll add a link to the page where they are in the chat for you all. And we plan to put the Q&A list in the same place. We'll be sending an e-message out once that's all set. We're aiming for by the end of this week. We really appreciate the time that providers took in attending and participating and sharing their ideas and questions and engaging with us. And we're committed to improving the process. I'm going to pass it over to Bill on that note, so he can give an update on how it's going.
Thanks, Kayla. So I would just give a little bit of update here about numbers, and I'll try to explain what the numbers mean as I go through them. So first of all, I just want to talk about where we were in case inventory, which is the total amount of cases to be worked in our system, the cases that have been submitted by providers. On 11/29, we had 1,294 cases. As of January 31st, that number had decreased down to 663 cases of inventory. And as of this morning, it was 610. So we've seen a substantial over 50% reduction in case inventory. What I'll talk about next is what we call our turnaround time, what I call the TAT time. This is the amount of time it takes Gainwell to process the case, which is, for everyone's information, the amount of time from the date is submitted by the provider till the date it is completed from Gainwell, meaning it's done the credentialing process, and the provider is able to submit another case. And there is a little bit of time that can be deducted from that, and that would be instances where the case has been sent back to the provider to fix an error or upload a document because Gainwell can't work it at that point. Or we also deduct out from that time when the case is in a state queue. So someone on the state side is reviewing a component. But the average turnaround time, and it's measured on a monthly basis. So basically what we're measuring is what was done that month and how long it took to complete those cases that month. So the average turnaround time for closed cases, again, it's an average. In November, that was about 55 days. In December, that had reduced down to 40 days. And in January, that's 33 days. And those are calendar days, not business days. The flip side is we also want to take a look at what is the average age of our inventory at any given point, because that lets me know how long, where are cases, how long have they been in the system, not just the ones that are being worked. As of the end of January, we had our average age of a case in our system was 28 days. And 64% of cases in inventory as of January 31st were somewhere in the 0 to 30 day range. Obviously, that means 36% are over 30 days. And again, that's of I'm basing that off Gainwell time, not full-time from submission, which includes provider time. So we have seen, improvement on the numbers. We're not done yet, but we're continuing to drive those numbers down to reduce the amount of turnaround time and time it takes for a provider's case to be processed. In addition, we do have currently 3 changes to our system to improve the provider enrollment process that are planned to go in for February. We're assessing other system changes as well, including automation of license verifications, expanding off of what we've done there. And we have filled a state vacancy on our enrollment team. That person started yesterday. So that will also help us on our end, as well as we're engaged with some cross-training with our provider relations team. And as Kayla mentioned, we are in the process of putting together responses to those questions as well that we received in writing at the provider enrollment session. That's the current status of where the numbers are for provider enrollment.
Any questions? Laura?
Good morning. Bill, thank you so much for that update. I know during the session in January, the question of kind of metrics and how the department was looking at that progress had been raised. So I think these are really helpful to hear and to hear in the months ahead. My question is about a new policy, or it seemed new to me, that had come out in the last couple of weeks to providers that if they did not respond within 10 days to, I'm assuming something back and forth between Gainwell and the provider, that case, it sounded like, would go to the bottom of the queue. Could you speak more to what was currently in place and some thinking about, how you came to the 10-day window?
Sure. It's not necessarily new, but really an adjustment to an existing process. So when a case gets sent back to a provider, a while back, we had implemented a process in which the provider had 15 calendar days to acknowledge and respond, maybe not fix the problem, but at least acknowledge that they were aware the case was back with them and they would be working on it to fix it. And if after 15 days and 3 outreaches from Gainwell passed without any response from the provider whatsoever, case would move to the bottom of the queue. The case was supposed to deny. And the provider would then have to go back in and resubmit that case. We engaged with discussions with Gainwell and internal assessment on that in terms of perhaps shortening that period of time and the number of outreaches, and ultimately came down to because obviously the amount of time making outreaches takes away time, could be processing other people's cases. We did some back and forth about what the appropriate time frame was, but ultimately decided that, 2 outreaches to a provider over a 10-day period, in our minds, was sufficient to at least elicit some sort of response from the provider, like, okay, yeah, I'll work on that. And or just getting back to us that they would be addressing it, and then we can just let it lie. But if, otherwise we'd want to just, close the case out. So that was our thinking. It was just a slight reduction of 5 calendar days and a drop from 3 outreaches to 2.
Thank you.
Sure.
Any other questions?
I have a really quick one. Bill, this is really helpful information. Thank you. I was just wondering on the 36% that do exceed the 30 days, if there was some data on 60, 90, 120 days, and if there's some consistency in, let's say, the 120 plus bucket or 90 plus bucket, if there's some consistencies there with why it was taking so long, or if it is really just individualized and there's no real rhyme or reason on the provider side or Gainwell to work through those.
Ballpark numbers. Thanks for the question, Mark. Ballpark numbers. We break it down into then 30 plus to 50, and then over 50 is just the last one. Because obviously our expectation is that cases should be done within 50 days or less. So I think 20% of cases would be in the 30 to 50 range, about 16 being higher. Looking at the cases and provider types, it really is individualized. Some of them are revalidations, which tend to be, larger cases. I think they probably skew towards revalidation and new enrollments, but I haven't seen anything that says, oh, it's a certain provider type that seems to have this. Although certainly, the number of work objects a case would have would certainly potentially play a role there. So like, think of your larger hospitals as the example I always give, who are putting in 200 physicians. It's, it's a lot more work than somebody who's adding 1 social worker.
Okay, that's helpful. Thank you. And a suggestion that you had made that we are certainly looking into, and this was, I think it's an every 4 or 5 year challenge for us with the revalidation, but of using multiple MPI numbers for the same service is a strategy that we're kind of still noodling through. But is that one that you would recommend to those that have a very large number of cases to work?
Yeah, if they do, it gives you a little bit more flexibility. I mean, I certainly understand the operational things that have to work on the back end for the provider side, but it allows them to have multiple cases open, which gives them a little bit more flexibility of saying, well, I got this new shared living provider I want to put in. I got these 2 cases done. We'll put them under this NPI. And at least, it tags your date in there. Even if I can't move that case to the front of the line, at least you've submitted it, meaning, you'll get potentially your retro enrollment to the first of the month in which your case was submitted. And I do know we have a few providers that actually have run out of the +3 numerators. Which is always good, because I have heard from time to time that CMS's issuance of the NPIs can be not as fast as one would hope. So it's always nice to have that in your back pocket, I think.
Great, thank you.
Mallory?
Thanks. So Bill, did you say, or did I miss it, what percentage are the over 50 days?
I think as of 1/31, I believe it was 16%.
Okay, thanks.
I didn't run all the numbers and calculations further back for earlier ones. Just didn't have that time. But
That's good. Thanks.
Becca?
Thank you. I missed the Gainwell presentation, so I'm sorry if this, you know, was explained there, but in looking at the top reasons for, returns in their slides, I'm wondering if there's been any like analysis of like where there are patterns of a lot of applications being sent back. Like when I see like it looks like a mismatch between the address on the license doesn't match the service location. Like my impression is that a lot of the licensing is tied to the provider's home address. And so I'm wondering if like, are there a lot of those rejected because it may be like kind of an across the board problem that could be somehow solved, and maybe I'm wrong about that. I'm not a licensed provider, but my husband is, and I know his license is on our home address. So, I'm just
Sure.
curious.
I think there has been, and I think one of the responses is going to highlight some of the big issues that we see. Some of it is names that don't necessarily match up between what the IRS has on file and what we have on file. That's a big one. With regard to licenses, it typically is not an individual license. That's not shouldn't cause that issue. It's when the license that someone is trying to enroll in our system is not necessarily the same as the license that is what is on the actual facility license. And so that is an area of that. But I think the responses that you're going to list like the top 5 or 6 areas where we see like the most errors or return cases. And I think it's W-9 forms, IRS licenses, and I can't remember what else was on the list as I sit in front of you today.
Yeah. Okay, great. Yeah, I think that would help probably reduce a lot of frustration on both sides.
Anything else, Bill or Kayla, that you want to share? Okay. I see that. Oh, Kayla, go ahead.
Sorry, my mute button is not working for me. I was just going to say I'm all set.
Same.
Thank you. I see that Michelle Probert is here with us now. Michelle, do you want to introduce yourself and then do any updates from MaineCare?
Yes, good morning, everyone. Michelle Probert, I use she, her pronouns, and I am MaineCare Director. Nice to see folks this morning. My primary update is to respond to a request last time to talk about authority and process for use of the MaineCare Stabilization Fund. For those who were not here last time, that request was made in the context of discussion around the fact that we have not made January 1 cost of living adjustments for certain rates, a number of behavioral health rates, as well as sections 2 adult family care home and 26, I think, adult day health services, because of insufficient appropriations to make those adjustments effective January 1. And the question was asked, why don't you use the MaineCare Stabilization Fund, since as part of our rate reform statute 3173J, trying to use that citation instead of Chapter 639 now, that does give us authority to use the stabilization fund. So I will share my screen. Give me a moment. I did not prepare slides, so I'll just be sharing a screenshot of documents that. Okay, so just for folks who may not be aware, there are now 2 pieces of statute that authorize use of the MaineCare Stabilization Fund. The first bullet here is use of the fund in order to prevent loss of services or increased cost of services to a main care member. And then secondly, along with our rate reform statute that passed in August 2022, we have authority to use the fund for any rate adjustments that are basically not sufficiently funded by the legislature. I will note that just by the nature of the Main Care Stabilization Fund, when we use it for rate adjustment purposes, that's really a temporary fix because, you know, using funds from the stabilization fund does not provide for ongoing appropriation to support those rates going forward, right? So it's really most appropriate for a mid-cycle adjustment to kind of get us to the next appropriation where we can make sure that the rates are fully funded. And I'll give an example of that when I am going through the puts and takes into and out of the Main Care Stabilization Fund over the past few years. So how do we, so that is our governing authority in terms of our process for use. First, I'll just note that the legislature can and certainly does stipulate specific uses of the fund. We also are, we need appropriation from the legislature in order to make sure that there are dollars in the fund. And when there are dollars in the fund and we have an appropriate use per our authority, the process is that we need to request a financial order. We need to include with that financial order our justification, which would either show that for example, if we are using the fund because of concern out of loss for service, then we can show our projections that show a deficit. If we are requesting funds, for example, for a cost of living adjustment, then we would need to show our projections for what that adjustment is and that we do not have appropriations otherwise. That the financial orders for use of the stabilization fund do need to be approved by DAF's Department of Administrative and Financial Services, I think is what DAF stands for, and the governor herself approves all financial orders as well. So that is just a bit of background. And then I will show what has been happening with the stabilization fund. While I'm doing that, if anyone has questions on the first part, feel free to chime in. All right. Can folks see this okay? I tried to make it as big as I could. I see some head nods. Okay, so this is just going back to 2019. This shows the fiscal year, what the beginning balance was of the fund, any transfers into the account, any expenditures from the account, the source, kind of what was the driving force behind those transfers or expenditures, any citations as relevant. I've got a little bit of narrative description over here and some additional notes. So in 2019, the legislature added $29 million to the stabilization fund, and that was appropriated really for costs of expansion. As well as disallowances. I didn't actually double check on that, but I'm guessing that that might have been related to the Riverview disallowance, which feels like a very long time ago now. So that appropriation was made in 2019. It was still there in 2020. In 2021, we, even though our rate reform statute had not passed yet, we had conducted our rate system evaluation, and we actually requested $90 million from the legislature to go into the Main Care Stabilization Fund with the intent of using, having the $90 million there for rate reform. We did not receive $90 million. We received $40 million. And then in 2022, the legislature directed the department to use 12 million out of the stabilization fund to assist certain hospitals with the repayment of Medicare loans. So that was not a department initiative. The legislature asked us to use funding for those purposes. The intent is for the hospitals to repay those loans, but that those will not be repaid until FY25. All right, so bringing us to 2023, a couple of things happened. First, and the way that dollars get transferred is a little funky. So even though it was in FY23, the legislature appropriated 6.5 million to the fund. This was to ensure that there were sufficient funds to make a disallowance payment to CMS related to the service provider tax. If you want to know more about that topic, there was recently a department blog about the service provider tax and disallowance. That 6.5 million was actually not transferred until this current fiscal year here. So 6.5 million additional were transferred into the account. In 2023, we did utilize Medicare stabilization funds per the authority that we have under our rate reform statute for the rate increases that went into effect in January 2023 for behavioral health in sections 2 and 26. We asked for an appropriation that went into effect in July of 2024, but we needed the 20 million in order to fund those adjustments and increases for the period from January 1, 2023 to 6/30/2023. So that is an example of where we did use the Medicare Stabilization Fund for rate reform efforts. We asked to restore that $20 million so that we would continue to have funding available for rate reform. We did not receive that appropriation from the legislature. And then that brings us to current fiscal year. In the next month or so, CMS has sent us the disallowance for the service provider tax, and we will be using the $29 million balance to make that payment. So basically, we are not going to have any dollars in the Medicare Stabilization Fund after we make that disallowance payment. And so there are no dollars available for use this fiscal year for any rate reform purposes. And that's the story.
Thank you for that. Are there questions? Laura?
Good morning, Michelle. Thank you. That was really helpful background on the stabilization fund. And when I read the blog post, I was kind of piecing together probably what had happened, but this helps me imagine then the situation of needing allocations for the COLAs for those behavioral health and IDD targeted case management rates. I think that the question is a little, then how do we go about and or what can the MAC do and or providers do to advocate for those allocations? Clearly, the governor's coming out with a supplemental budget. I don't know if you can speak to what you imagine seeing in that, if the allocation would be there, but I can also imagine that we'll know soon enough whether or not we need to, advocate for those dollars to be there to secure the COLAs for January 1 that are pending.
Yes, I cannot speak to what will be coming out in the supplemental budget. I will say generally, though, that clearly we have we have a couple instances where we have requested substantial appropriations to the stabilization fund in anticipation of the fact that we you know, we are very much actively reviewing in the rate determination process for services, and it is useful for us to have funding available to put towards the recommendations that come out of those rate studies, because otherwise we're in a cycle of, you know, we don't know how much something is going to cost, and we commit to assessing what the reasonable rate is, and sometimes we guess what it's going to cost, but we may not be right. And so there's been recognition by the department from the outset that that it is helpful to have funds to fall back on so that we can implement the rates that we feel are appropriate. So I just would certainly generally encourage that when we make requests of the legislature for appropriations to the stabilization fund, that you support those requests and talk to your legislators about those requests, because it this current delay of the cost of living adjustments is a great example of a case where we did not have any funds to access, and so we're not able to act as we would have preferred to.
And I guess a quick follow-up would be, you know, our next MAC meeting is, you know, in March, hard to believe, the budget will come out, the hearings will have happened. So if, you know, if it's possible for you to let this group know what you see in the budget and what you might need support around, I think that would be really helpful. I'd appreciate that for one. Thank you.
Okay, great, thanks.
Any other questions? Go ahead.
Nope. If we were finished with that topic, I was going to give one other general update, Kathy. That's so this could fit under the rate reform updates as well, but I'll just share now, generally speaking, that 'tis the legislative season. We have had a number of, we've seen legislation as well as received requests from some providers regarding services that they would like to be on our rate determination schedule, or rate adjustments that they would like to see within this fiscal year. I would just, I shared the same update at our cross office meeting within the department this morning to make the same request of our other office colleagues. But just a reminder to all of you, and please help spread the word, we do have a process in statute for getting public input and trying to determine our rate determination schedule earlier in the year. And for 2 years now, and you know, we're never all going to remember absolutely everything, and it's never going to be perfect. And the statute acknowledges that the department is not restricted to that schedule, but it is a public process specifically so that we can get your input and your help in figuring out what our priorities should be. And so it is frustrating when we don't hear about something at all until after we have determined that schedule. And sometimes what comes up is it's a valid point, it's something we'd like to address, but given the formal process we need to go through for rate determinations, given the fact that most of the time rate adjustments are going to cost money and so should be reflected, as we just talked about, in the budget process, especially if we are out of funds, Maine Care Stabilization Fund, it ties our hands. And so prospectively, please help us in getting the word out to really try to actively be thinking about what are the pain points, what feedback can we give, what are specific services where it seems like something might have been missed, et cetera, so we can know about that and try to adjust that, or at least take it into consideration in our overall prioritization sooner rather than later. So that is just a general request. And as I said, we do acknowledge that none of us are always going to be able to predict everything, and we do care about having adequate and reasonable and fair rates, and so we do try to do what we can, even when something may not be on the schedule, but we can't commit to those things because again, it can cost money that we may not have, and also we are stretched very thin just in terms of the scope of work that we have on our plates already.
Mallory and then Mark.
Thanks. Thank you, Michelle, for that. That's that overview of the Maine Care Stabilization Fund itself was very helpful. One piece when we're talking about the rate study calendar and reviews, one thing that's come up is Section 23 was getting reviewed and is in the process, but the one section of Section 23, the child abuse medical evaluation, was not included, and we had assumed that it would be part of the whole of Section 23 being reviewed. And it has not been it has not been reviewed for, over a decade. But I had heard that there might have been some discussion within the department about opening Section 23 further to look at that. Is that accurate or not accurate? Is there anything that's looking at it, doing the entirety of Section 23 as opposed
Yep.
to?
So so Section 23, there was a rate determination for Section 23 stemming from legislation from a few years ago. There had never been an appropriation for that legislation, but it was directing us to establish a new bundled service and accompanying reimbursement. So it is a good example of actually don't remember if it was officially on our schedule, but but there had been work in progress to update or to create this service per the legislation, and so it came on our plates, right? But because it was really the result of legislation, it was not a comprehensive look at Section 23 at the time. And I know that I remember reviewing documents where it try to indicate like this is a specific service within Section 23, not Section 23 as a whole. But I will say that I don't know if we were 100% successful at always making that caveat. And so I do understand that there might have been some misunderstanding about the scope of that Section 23 determination. And again, that really was a result of kind of catch up on old legislation. And it would have been ideal if it had been a more comprehensive look. But at the moment, we have only done the rate determination for the one service. I think that there are a couple other rates within that section of policy.
So given that it was a very narrow review of Section 23, the rest of Section 23, specifically the child abuse medical eval, is not on the schedule anywhere. If there is only one provider left in the state that actually does that service, and they are looking at ending that service because it has not been reviewed and is like pays out at a third of what the psych rate is there anything that can be done? I mean, does that rise up in any way? I'm not sure in the processes that we have currently how that can be addressed.
Yeah, so I mean, I think it is rising up, and that I think that there is draft legislation out there to this topic.
Well, there's potentially going to be legislation if that's the only way to move it forward, I guess.
Yeah, this is one of the examples of a case where I cannot commit at this point to it. The full section of policy was not on our schedule, and we have other high priority items underway as well, and they're also yeah. So this is a great example of what I just stated is when we're in a difficult position, and I can't make commitments at this point.
Okay. All right. Thanks.
Mark?
Great, thanks Kathy. Thank you, Michelle, for the history and the review and the ins and outs of the money. Can you speak to the dollar amount that is needed to cover the COLAs? If we were able to get an appropriation that covered what type of dollars we're looking at to get that funded?
I am not prepared to speak to that right now. I think that it may be helpful to have this discussion next month.
Okay, sounds good. Thank you.
Thank you. Any other updates you want to share, Michelle?
Probably I missed Ian. So Ian, I'm guessing that you already told folks about the February 13th session on unwinding. I see Kathy nodding, so.
Did, I forgot to put the link in the chat, so I will do that right now. Thanks for the reminder.
Absolutely. I think that's all I've got. Thanks.
Thank you. So we did some part of the provider updates, but are there, Mallory, do you want to jump in with any updates from the subcommittee?
Sure. So the subcommittee did meet with Bill Logan and had a great overview of the program integrity process. In that conversation, we, found out about, maybe how we compare to other states and what's happening in other places. The notes will be coming out, but, there was clarification that like the recoupment percentages are set by statute and rulemaking. There is some possibility that providers, can request, corrective action in lieu of penalty or lower penalty given, very minor documentation errors as opposed to, more egregious or larger errors in the process. So there is some, I think there is some flexibility in it that I think providers may not have been aware of, which I think is important. So that was a really good presentation and overview. We discussed the paid family medical leave issue and how that will impact main care providers. The fact that, and I have brought this to Reggie, I can't think of Reggie's last name, but who is sort of heading up in the Department of Labor. But main care providers, we do have this great new legislative process for rate review and on a regular schedule. And so there is some request by main care providers, I'll just share here with the MAC, that main care providers be considered as a small employer until the rate that they are providing services under goes through rate review and the cost of joining the paid family medical leave is incorporated into their rates. So right now, if you have 50 employees or less, as this rolls out, you do not have to pay in as the employer, but your employees can pay in and have the benefit of the system. And so what we were hoping is that main care providers would be able to be considered in that category until their next rate review when the costs could be incorporated. So they don't have undue burden of increased costs through this other program that's not included in their rate review process. So that's going to be we're going to be pursuing that. Then the only other thing was that a topic for next month would be, there was recent January 1, Centra Health and Office of Main Care is reinstated the original submission window for requests in the Atreza portal. There is desirability on the part of providers to keep some of that flexibility, so we may have that as a topic of conversation at the next MAC provider subcommittee, whether or not that's any potential to that or not. And that's it for my update. And if anybody, again, wants to join, let me know. And if you have any agenda items, let me know, please, in advance. We meet at the last Wednesday of the month, and that way I can make sure Main Care has notice to join us and discuss whatever the topic is.
Thanks, Mallory. Any questions? Okay, let's move then to the rate system part of our agenda. And Amanda, do you want to kick off with any updates? I know we heard about some things related to rates already.
Yes. Yeah, sure. I didn't, we met last week on the 29th with Laura and her group. I wasn't able to get the monthly update out or posted until this morning, so I'm going to put that in the chat. I did verbally give that update there. Had some good discussions, some of what Michelle's addressed this morning, which is good. Other than that, I will say that we are rolling out the implementation of Medicare standardization notices. We have a few more to do over the next couple of weeks. Most of those have been implemented, and we are continuing to make updates to the website so that it's easier to use, more organized, and other improvements like that. I think that's all I really had.
Great, thank you. Any questions for Amanda? All right, Laura, is there anything you'd like to share?
Oh, sure. You know, as Amanda said, the subcommittee met last Monday, and we were always happy to have Amanda on hand to give an update, both on rate determinations in process and then on the website and the great changes that are being made there. We did discuss a little bit about the COLAs and the appropriation, and assuming, you know, the department has made a request, we'll look to the supplemental budget and have a recommendation to the MAC at large that the MAC supports appropriations for the pending COLAs for January 1. Our next meeting is Monday, February 26th. The focus of that meeting is going to be 2024 planning. It was great to hear, Michelle, you mentioned, you know, about the timing of rate determination schedule for that would be 2025. So we'll want to work with Amanda about the department's thinking about moving that up and being prepared as a committee in MAC to look at that schedule in the year ahead. So for folks who would like to join the meeting, we generally meet the last Monday of the month at 2 p.m. I put in the chat the next meeting date, February 26th at 2 o'clock. Again, our focus is going to be on 2024 planning, but if you ever have any questions or an agenda item, please reach out. Thank you.
Thank you. Any questions? Okay, then next up is the rulemaking packet. Kristen, do you want to share updates there?
Sure, thanks, Kathy. So since our last meeting, we have adopted a few different sections of policy. We filed our adoption for Chapter 2, Section 29, which is support services for adults with intellectual disabilities or autism spectrum disorder. And we also filed our provisional adoption of the Chapter 3 for Section 29 as well. We adopted our Section 43 hospice services, both Chapters 2 and 3 in mid-January. And we have a couple of rules that are currently in pre-review with the Attorney General's office. So Section 20, Chapters 2 and 3, so that's home and community-based services for adults with other related conditions, as well as our Section 31, federally qualified health centers. We also just proposed the end of January, our Section 23 developmental and behavioral health clinic services. That hearing is scheduled for February 20th, so be on the lookout for that as it relates to your organization. And then last update that I think is most relevant is we will or anticipate seeing in the coming weeks our filing of our adoption for our Section 94 EPSDT or early periodic screening, diagnosis, and treatment policy. I think those are the big updates. Does anybody have any questions about specific sections or rules or content?
Thanks. I have two questions I actually think maybe are more for Ian than you, Kristen, around
Okay.
OFI rulemaking. One, I had a couple of questions. I know this was discussed last month and I missed it, but around timing, people are very appreciative that OFI's removed the asset test in the MSP program, but wondering, there were some pieces that were supposed to be implemented in March and wondering if there's a timeline for those pieces. And then I guess related is, well, I'll ask that question and then I'll come to the other question.
Sure. So for the asset test removal, we adopted the rules related to Dell. The MSP asset test is also removed on January 1st of this year. And the retroactive rulemaking is still pending, but you should see proposed rulemaking related to that soon. But either way, just to clarify, because I did get some questions after the last meeting, the asset test is removed for Dell and MSP, and I'm just trying to pull up. We also updated the FPLs on our website, and I'm just pulling them up. They're available at this link. This is all the 2024 FPLs, just to be clear. And so the eligibility guidelines on our website also have the current FPLs for the 3 coverage groups for MSP, as well as a note saying that there's no asset test. So I think all the public messaging here should be clear. I get wanting to see the rulemaking too, and we're still working on that. And then, so do you want to ask your next question?
Yeah, but the other question was around, I know we've talked a lot about the implementation of the expanded coverage around CHIP that went into effect in October. Folks are still wondering if we have any sense of timeline of when rulemaking for that will happen, because while we appreciate that it's implemented, having the actual rules would be helpful.
I did not, I'm gonna just check if Jess, if you had a later update on that. Otherwise, I can get that for you next month. Sorry, I didn't have it.
Actually, those 2 rules are tied together, so they'll go
that's what I thought.
together and we're working. We are waiting for some information, which we received, so working on getting those hopefully soon.
Okay, that's what I thought too. So
cool.
thanks for confirming.
And not rules, but we did get our state plan amendment approved for the postpartum coverage for pregnant people without oh gosh, it's always such a mouthful to say. For the eligible public pregnant population, I will say.
Yeah.
So we're making progress.
Yeah,
Implemented,
that's
we
great.
have the federal authority working on the rules.
Yes, that's really good.
And we also, for that same population, we also contacted everybody who had closed in 2023 under the old, I can't remember the right word, under the old process.
Yeah,
Under the old eligibility guidelines, people closed prior to January 1st, and we contacted everybody who did close and let them know that they may be eligible and could apply again. Unfortunately, it's not a automatic process because they closed correctly under the guidelines that were in existence at the time that they closed, but we did contact those members directly to let them know and assist with regaining coverage if they were still eligible for it. So that process has completed. I don't have the number of people I don't have the outcomes of that process, but I know that we did the process.
That's very helpful. Thank you. And I know several MAC members that are on here today have also been trying to help with outreach around that change.
Great. Thank you.
Any other questions around rulemaking or waivers or state plan amendments? Okay. then I believe that that is everything on our agenda. Our next meeting is in March, and it is March 5th at 10 a.m. And I made a note to check in about updates related to the budget that feel important to lift up for the MAC, which we should have by then, and also about the rulemaking that Ian just named, and see if there's any update on timing. And I think we'll continue to have updates on unwinding and updates on the provider enrollment issues with Gainwell. Is there anything else that came up as an agenda item for next month that I haven't said out loud?
Kathy?
Yeah.
Just real quickly, and I don't, it doesn't necessarily need to be on the agenda, but I know several months ago we had entertained as a group doing some strategic planning, and I wondered if we could, you know, revisit the plan to plan. Thanks.
Yes, that is a good idea. I'm going to give a friendly suggestion that maybe we try to do that in April when some of us might not be quite so stretched with the legislative session. We'll still be in legislative session, but hopefully more close to done. But I'm going to write it down so I can remember that for April. And Ian, were you trying to say something too?
I can't remember if you included it in your list, but we were going to go back. We'll have some other information in the regular unwinding conversation about specific populations that we're seeing in the pending category to inform outreach efforts this summer.
Great, thank you. I didn't explicitly name that, so thank you. Becca?
Hey, Kathy. I guess I don't know what the agenda item would look like exactly, but it feels like we need to maintain some sort of tie between the dental subcommittee and this larger group.
Yeah.
Yeah.
Great. Anything else? All right, well, letting you all go early, which I'm assuming would be helpful for most of you, and to have a wonderful rest of your day and month.
Thanks,
Thank
Kathy.
you.
Thank you.
Thank you.